Let me invite Dr. Fuster, the physician-in-chief of Mount Sinai Hospital, the president of the Mount Sinai Heart, Richard Gorlin, professor at the Icahn School of Medicine, Mount Sinai, and mentor to all of us, Dr. Fuster, for a very important topic, subclinical and clinical atherosclerosis, accelerated epigenetic age, inflammation, or both. Dr. Fuster.
Thank you very much for the invitation. And it's a pleasure to talk about a subject that I think is new, exciting in my view. Well, over the last few years, I have been working on the transition from cardiovascular health to cardiovascular disease, and particularly working in subclinical atherosclerotic disease. There's a title today that you may question what that means: accelerated epigenetic age, inflammation, or both. Well, let me define the situation. This was in the 1990s when we worked a lot into the understanding of the progression of atherothrombotic disease towards older age. And I don't have to go into the details. This was a two-part article really pointing out the issue of plaque rupture, thrombus formation, apoptotic phenomenon of the macrophages, something that I think has evolved over the years. So we move from here in the bottom, the understanding disease, to the top, how the disease begins, in three different ages, in particular with very new technology. Well, we were in about 2016, we began to pay attention how the disease begins. And these are the risk factors that we all know, and here are the genetics. And the question is how these risk factors and genetics work in the arterial wall. And what about the defense mechanisms that prevent us to develop disease? I think what is important is at that time, right or wrong, we thought that the main role of the risk factors and genetics were direct effect into the vessel wall. Opening the vessel wall, smoking, hypercholesterolemia, and then with the transition from the blood flow to the artery with cholesterol deposition and so forth. Well, this was 2016, and this is an example of how science moved and how wrong we were. Let me go, I'm going to concentrate now in people between age 20 to 60, because this is an age that the challenge is, are we developing the atherosclerotic process? And as you many know, we began a study in 2010 in Madrid, Spain, of 4,000 people, over 4,000 people, that we are following until the year 2029, 2030, from a very meticulous point of view. Here on the right, you have imaging technology, which is ultrasound, CT, MR, PET, and so forth, every 3 years in these individuals. And this is related to the risk factor profile. And then there's a second part that I will emphasize today. What about the role of genetics in all of these, other than imaging? Well, let's begin by saying what we learned with imaging. And basically what we learned is with 3D ultrasound now, we can screen the carotid arteries, iliofemoral arteries, and aorta, and then indirectly calcification of the coronary arteries. So are actually 6 segments that we screen. And basically one thing that is interesting, the disease starts in the iliofemoral region, but is not clinically evident because these are very large arteries. And then the disease spreads. This is a very systemic disease, by the way. And what we learn is that certainly these are males under the age of 50. You have 2/3 have already one of these 6 regions with disease, 2 or 3, 4, 5, or 6, and now 50% of women. But there's something recent that is interesting. What makes the disease to progress? Because as I mentioned, we test them every 3 years. So we have at 6 years, 33% of these people overall have progression of disease. And the question is, what are the role of risk factors in these 33% of people that the disease progress? Well, in terms of question number 1, this is actually going to be published in 3 weeks from now. We have 33% of people in red, means the disease progressed. This is a baseline, and this is actually in the vertical axis. And we quantify disease with 3D ultrasound with cubic millimeters of atherosclerotic disease. This is how we quantify. I will say that in 10% of people, there was regression of disease. Well, I don't have to go into the details. These are the carotids, these are the iliofemorals. This is an example of progression of disease. Here in the carotids, this is an example of regression of disease. I don't want to spend time on this because I have more important things to say or more relevant things to say. The interesting thing was the risk factors, and this is surprising to us. Younger you are, higher is the likelihood that a risk factor like LDL cholesterol or hypertension will have an impact into the blood vessels. Let me give you an example. If you have an LDL, let's say, of 140 at age 40, and you have 140 at age 60, the impact into the vessel wall is much higher younger you are. So one thing that we are learning with all these studies, beginning with young people, is younger is your blood vessel, is more prone to trouble with the risk factors the older you are. Completely the opposite, I think, of what we thought, but this is actually what we are learning. Well, so going back to age, what I showed to you is the disease begins at young age. Actually, it's at age 20. But let me move into the second aspect that we learned. Let's now look at the risk factors by themselves, not the disease, but the risk factors at age 20 to 40. And this is the Cardia study. These were 5,000 people that we have between age 20 to 40, and we look in the abscissa is the age, in the ordinate is the LDL cholesterol. So the only thing you have to do is to measure this area and to know the impact of a risk factor between age 20 and 40 with HDL, triglycerides, blood pressure, and so forth. Well, the results are striking, actually. And what we basically saw is that higher is the area in LDL cholesterol, 20 to 40 years, higher is the likelihood 40 years later to develop a cardiovascular event. Now I could spend time on all of these. I don't want to. We found the same with triglycerides. By the way, you have to drop triglyceride level very low, and you see what happens. Unless it is very low, the disease progresses, blood pressure and so forth. So what we are learning is the disease begins at a young age. The impact of risk factors on progression is more important younger you are. And at the same time, just looking at risk factors alone, and you follow these individuals years to come, 20 to 40 years, you see the impact that young age has. Well, and finally, perhaps most interesting is what you go to the guidelines. I have to say, and I don't mind to say it, are absolutely primitive. The guidelines look at heart attacks at Framingham at age 50, 10-year follow-up, 30-year follow-up. Let me show you the data on subclinical disease. We started actually in 2017. LDL cholesterol is considered normal between 1800 and 10. It's considered normal. Look, the amount of subclinical disease in color. You need to have an LDL less than 70 if you want to have no disease once all the other risk factors are controlled. Then we said, let's move now into diabetes. Here is pre-diabetes, the amount of subclinical disease. So pre-diabetes is not an alarm system for diabetes in heart disease. It's a problem already. But even recently, what we have found, and I guess this will be published very soon, that before pre-diabetes, just the time of insulin resistance, there's already significant subclinical disease. Remember, we are dealing with 4,000 people, and all is done blindly, and is every 3 years are being followed. And this is the role of imaging. So we cannot really go to Framingham at age 50, see what happened, because you miss what happened at age 20 and 30, which is probably more relevant, as these studies are actually showing. And this led to a study that we are going to start, the PCAT study. People between age 20 and age 40, in fact, we increased to age 50, I have to say. Some will be actively treated because with LDL more than 70 is abnormal already by subclinical disease, and the others will be treated conventionally. And here the critical issue is the primary endpoint. They are so young that you can only measure progression of disease rather than cardiovascular events. And then you will say, well, progression of disease doesn't mean cardiovascular events. Well, just wait for a minute. This is how we are going to treat these people aggressively over age of 70 with inclisiran, okay, every 3 months with an injection, subcutaneous injection. And I don't want to go into the detail of the standard treated group. But what I'm saying is we are now completely, I would say even obsessed about what happened between age 20 and 40, because we have missed this, and that's the time of real trouble if you go back in the natural history of the disease. Well, having said that, let's go to the primary endpoint, and I said this young age, progression of disease is the only thing you can look at. Well, not necessarily. We have a similar study with 3D ultrasound that we did, the bioimage study, people between age 60 and 100. And actually, this study preceded the Madrid study. It was done in the United States, in the area of Chicago and Florida. Actually, 6,000 people. And what we did is, let's see how ultrasound can project mortality 13 years later. So we got the data actually 2 months ago. Second question, what about if the disease is progressing for 10 years? The 3 years that are left to 13, there is an increased mortality. So then it's to look at the role of progression of disease into mortality. Well, this is the data very rapidly. At age 60 to 70, there's no question that the burden of disease by ultrasound predicts at 13 years later significant mortality. And just to go quickly into this is the people who progress during the first 10 years. What happened between age 10, between 10 years of follow-up and 13 years of follow-up? Significant mortality compared with the group that progressed less. So now in the pre-cut study, the statisticians are in agreement. We can see at age 45, let's see the burden of disease, what mortality would be if this patient was age 60. That's basically what's going to happen. And you would say it will be worse because he's age 60. Actually, you are wrong, because younger you are, the disease is worse. So you cannot say that you project something that is much higher risk. It's not. So this is basically how the study is going to address. So let me tell you what I said. Very simple. We have to identify disease very early. And then you have to do this with imaging of external arteries. Actually, in countries that cannot afford, we are just doing this in the iliofemoral region, and we actually do not extract blood. We look at the risk factors without looking at glucose or cholesterol, because if you have obesity, lack of exercise, more or less, you have into a risk factor profile with imaging as the driving force within a period of half an hour and without drawing blood. So we are very conscious that everything we do that economically is feasible in the future for people who cannot afford. So that's basically what I presented. Well, now let's go into genetics, which we are very excited about it. This is not the study, I must say, 2010, I began to do the study only focusing on imaging, but there are many other people around you who are genetically prone that says, you know what, let's get into the genetics well. So I'm learning from them rather than being the driving force. The data is interesting. Well, first of all, Ana de Besa, I don't know if she's here today, but has been the driving force. And that is, we did positron emission tomography of the bone marrow and of the arterial system. And here you have, the bone marrow is activated in blue. And this actually coincides with what we see in the arterial system. And this is a combination of cholesterol and macrophages. And that's what you see with PET. Well, this is one study that was published in 2022. Now comes the interesting issue. Now we have 900 people of the PESA study that we did both positron emission tomography, bone marrow, and the arterial system, and magnetic resonance imaging of the arterial system. And let me tell you what we are learning. This precedes this. That is, lesions that are active with positron emission tomography, if everything is good and the macrophages are doing the right job coming from the bone marrow, the disease becomes fibrotic and calcium gets deposited. Very interesting. So in fact, this is what I call a war. And the war is between the substrate in the arterial wall and the reactivity of the bone marrow of how it takes care of the substrate, which is cholesterol. Well, now I tell you what is our hypothesis, right or wrong, is the following. That if the substrate in the arterial system, like cholesterol deposition, which is a foreign body, is not very high, the monocytes win the war, and the lesion becomes fibrotic. This has been seen at autopsy, actually, but this is in vivo. Very well compensated system. However, if the substrate is high, The risk factor profile is very high, and the cholesterol is very abundant. What happened? The monocytes cannot take care, and they suicide. Something Dr. Narula knows very well, and Dr. Vadimon, if he's here. And that is what we see is the monocyte has a defense mechanism. Today, the cholesterol are, but if he cannot do the job, it commits suicide and then releases tissue factors, the clots, metalloproteinesis, plaque rupture. So for us, the acute coronary syndrome is a failure of a defense mechanism because the substrate is too overwhelming. That's basically what we are learning. Well, these are actually a war between the bone marrow and monocytes and the substrate. But there's something else. And we began to work with the bioimage study and with other groups on the concept of CHIP, and that is clonal hematopoiesis. This is the concept. The concept is that when you have a plaque that has some cholesterol, the monocytes come in and take care of it. And the monocytes today are divided in 6 types. But preceding that, there were type 2 and type 1. This group takes care and the lesion becomes fibrotic. No problem. The problem is when there is something that debris of clots, a lot of fat and so forth, the interleukin 1 from monocytes that circulate go to the bone marrow and macrophages type 1 come in. And what is happening, they lyse the lesion. And that is, this is completely lysed. And this can lead to a lot of trouble. In fact, to the point that the Cantos study is a monoclonal antibody to the collar, which was interleukin 1. What is CHIP comes here? CHIP means that the bone marrow cells that are supposed to defend are mutated. And what happened? If they are mutated, they are not doing the job of defending you. And here what is happening is, in this particular case, what we found is that one of the genes, TT2, from the macrophages of the bone marrow, if it is affected by clonal hematopoiesis, the defense mechanism doesn't work. So either you have a lot of interleukin 1 that you can defend by having a monoclonal antibody, or you have very little TT2 and the process continues without a defense mechanism. This is clonal hematopoiesis, and this is called CHIP. Well, we approach this in the PESA study now, and I will tell you there is a new risk factor that is very powerful, and this is CHIP. And that is 20 to 35% of people, of the near 3,000 people of the PESA study have already clonal hematopoiesis abnormal mutations in the bone marrow. What that means that you may have a normal substrate of cholesterol, but the defense mechanism is not working. There is no motor engine. And you may say, my patient had a heart attack and no risk factors. Well, it's better we begin to understand genetics, because that individual could have a very high risk factor profile, but the clonal hematopoiesis problem is not working. The defense mechanism is actually not working. And we look at this, I don't have to go into the details, but we found the genes that are important, and TT2 is actually one gene that is very important in this second study. And one thing that is very critical in the PESA, since we are following every 3 years, what we found is the clonal hematopoiesis precedes the development and progression of atherosclerosis. So it's not the other way around. This is important because in the literature of the last 2 years, there's a conflict. What leads to what? It's becoming very clear, at least to us, that this is a risk factor that leads to subclinical disease and progression of subclinical disease. Well, this is actually, I can summarize what I said thus far. We have to identify the disease very early, as we mentioned, and now we are talking about gene variants. Sure, we look at LDL cholesterol genes and so forth, but what I talk is CHIP. It's a new kind of risk factor that is very critical and actually very easy to measure, by the way. And the question is, once you have these, you can modify risk factors and take care of. It's like the imaging. Once you know there is disease, I think we will have the people much more prone and sensitized to modify their conventional risk factors. Now I'm going to present what I think is new and is quite interesting. This is what we thought in 2016, and I mentioned this before, and that is all the risk factors and genes are just affecting the vessel wall, and as hypertension affects the endothelium, cholesterol keeps entering. Yeah, smoking affects the endothelium. Cholesterol keeps entering. This was the concept, diabetes and so forth. Well, this is nice to say, but our views are changing drastically at the present time. And let me tell you what happened. In the study that I presented by Ana de Besa, we were doing PET scanning of the bone marrow and of the arterial system. There was a finding that was published actually, and we didn't say much because we didn't know what it meant. If you go to the metabolic syndrome and you are in the fourth quartile, this is actually progression of disease. If you go obesity, incredible. If you go into hypertension. So basically what we found that the risk factors, when they are available, the bone marrow reacts like crazy, very active. And the question is, what in the world this means? And we didn't have any idea. So this was one aspect that we were very silent because we didn't understand it. But at the same time, there was something else that was happening. And this is the question of epigenetics. In the 2017 to 2019, there are a number of studies that show that DNA methylation of certain genes, they actually shorten life. And here comes the concept of biological age versus chronological age. The concept is fascinating. You may be age 90, but you are like age 70. Or you may be age 70 and you are like age 90. The question is what is happening. And the whole concept evolved with epigenetics. And that is, you have risk factors that affect the genes, and then your whole system is affected, not because genetically you are wrong, it's because it has been changed by the risk factors. This is the concept that evolved. So, we took this concept and we went into the PESA study. Here's the concept as it was actually in 2019. There are hallmarks of biological aging by epigenetic changes. Basically, if the methylation is low, biologically you are going to live much longer than chronologically. If the methylation of certain genes is high, it's completely the opposite. It shortens life and is the opposite. This is very strong, by the way, in the recent literature. Well, here are cardiovascular risk factor parameters such as body mass index, insulin, cholesterol, C-reactive protein, lack of exercise, smoking and diet have shown that they have a tremendous epigenetic impact. And the question that we ask ourselves is, maybe this is getting into the bone marrow, and that's why we show with these risk factors and activation of the bone marrow. So we went into the PESA, this was published actually a week ago. We went into PESA, and fascinating. What basically we found is, here is the different technologies. This is 3D ultrasound, calcification of the coronary arteries, 2D ultrasound, and this is actually a full relationship into what you see with the burden of disease and the epigenetic clock. And that is, this is a lot of methylation, a lot of methylation, and this is the technology. So a close relationship between measuring the methylation in blood and the activation of the subclinical disease, which puts this together. But most interesting is this. If you go to Framingham, let's say in blue is median risk factor. So everything, the events and progression of disease should be the same, isn't it? It's completely different. If you have an accelerated epigenetic profile, and this is in the PESA study, the risk is much higher than just what you would do for Framingham. So what we are learning here is very fascinating, and that is the risk factors have a huge impact on the methylation of certain genes that actually the proteins that come into the blood can have a bad effect in terms of the biological aging. And this is a complete change in our view of how risk factors actually work. And actually, this is the concept that we have now. You do methylation, you look at this, and then what you have, accelerated epigenetic age, that is high methylation, actually it gets into the bone marrow, the inflammation is activated, that's what we shoot with PET, and then you have subclinical disease. And that is, again, this is very fascinating. It's not the risk factors directly affecting the vessel wall, it's an indirect way by which you interpret this. And this has led us now to develop this concept, reject this concept, and that is, we are not sure that the most important role of the risk factors is the vessel wall. We feel that the most important role is actually methylation. And actually, the bone marrow is a huge protagonist. And this reminds me when 50 years ago, I began to work with platelets. And in the cardiovascular system, people told me I was crazy. And I only had to go to meetings of hematologists saying the platelet is important in cardiovascular disease. I can predict to you that the bone marrow is going to be in our heads very, very soon because of what I am actually discussing. And now, well, you know, all these guys who work in artificial intelligence, Lara Pesci, now they are finding all these methylation genes that are affected and beginning with artificial intelligence, beginning to develop a completely new concept of the risk of cardiovascular disease. So now I finish by saying that I think we have to start very early in life, identifying the disease and gene variants. Now, in terms of the issue of imaging, well, we know the bone marrow may be a winner if the substrate is low, but if the substrate is high, I think this may lead to cardiovascular events. And now new risk factors. If CHIP is high, the motor engine of the bone marrow is not working, and therefore the substrate wins, regardless of what is the quantity of the substrate. And finally, epigenetics. You have a significant risk factor profile that significantly affects the bone marrow. This is a winner versus the substrate. So these are two risk factors that really are very, very important in our view by following these 4,000 people every 3 years. With obsessive people on genetics, I am not. And I presented to you what is showing, but certainly giving us a sense that we are in a new era, and it's the era of imagenomics. It's an era in which imaging and genetics are going to play an important role in how we understand the disease. And you learn something that you cannot be dogmatic on anything, because it's no more than 4 years ago, we thought that the vessel wall is the place where all these risk factors actually have a role. And now with the PESA study, we are learning something completely different. So anyway, we have to be humble. Thank you.